Hi everyone, this is Morgan from the New England QIN-QIO, and the mute feature is not cooperating today, so if you could please mute your lines individually on your end, we would greatly appreciate it. I think we're going to go ahead and get started. So thank you for joining us for today's Interact discussion, which will mostly be a sharing and Q&A call with our Interact folks here, Carol Dietz, Florence and Sheila Eckenrode. Before we get started, there's a few things I wanted to go over. This call will be recorded, as always, for training purposes, and I'll remind you again how to access that at the end of the webinar. We tried to put the phone lines on mute, but once again, try and mute your own line if you can. We will be taking questions throughout this webinar, and we will tell you how to unmute your line at that time. For now, I will pass it over to Carol to get the webinar going. How do we mute it?
Good afternoon, everyone. This is Carol D. And if you could mute your line by pressing your mute button on your phone, that would be outstanding. And welcome to our 5th session on Interact. This session is going to be a little different in that we are going to be asking you, the nursing homes, how things are going, asking you to share with your regional colleagues on the challenges you have faced and that you have faced or are personally facing right now, and the solutions that you have found to overcome some of these challenges. Florence, Sheila, and I will be reviewing the Interact tools that have been discussed thus far, and we'll be asking for your input on how things are going and how your team has implemented these tools. As of right now, most of the Interact tools that have been implemented, that should have been implemented, have been internal tools, used only within your building. But starting next month, in July, the tools we will be discussing are some tools that will be sent out with your residents as they are being transferred to the hospital due to an acute change in condition. So it's very important that you have all the needed processes in place now for these internal tools, so as you begin to roll out the next set of tools, it will be a smoother rollout, and your staff will continue to work together to ensure a safe transfer for your residents. So just to sort of start off, back in February, I can't believe it's already been almost 6 months, we introduced you to the New England QIN-QIO. We talked about the role of the new regional New England QIN-QIO and how we're responsible for the QIO work in the 6 New England states, and that one of the goals of our work is to reduce the 30-day unplanned hospital readmission rate by 20% by 2019. And again, if you could mute your line, we would greatly appreciate it. Just hit the mute button on your phone. Thank you. So these are the New England QIN-QIO Care Transitions teams from Connecticut, Rhode Island, New Hampshire, Vermont, Massachusetts, and Maine. We are all working together to share best practices regionally, and then we are sharing them nationally with our national colleagues. And it's all about ensuring the safest transition possible and to reduce adverse drug events in all settings. So, I am now going to be turning the microphone over to Sheila to begin discussion on the Interact tools that have been discussed thus far. Sheila?
Well, good afternoon, Interact partners, and welcome to our midterm review. Here we are, 6 months into it, as Carol said, and want to take a moment to pause and see how far people have gotten and how we're progressing as a state and as several communities in this initiative. Well, we all know what Interact is, and we all know that this is about reducing unplanned readmissions. But I would like to take a moment to encourage you to communicate to your staff that what Interact is really about is identifying and responding to changes in resident conditions. I get some feedback from nursing home personnel that this program is about keeping their residents away from needed acute care, that this is a way of Medicare kind of saving money and not letting people fully take advantage of their benefits, and that's not what it's about. It's about identifying changes in resident condition early, responding to them appropriately, and getting our residents the right level of care the first time. So that's how I sell it, and I encourage you to do the same. Again, we know that the components of the program are quality improvement tools, communication tools, decision support tools, and advanced care planning tools. And we're halfway through all of them. Way back in February, it was cold and stormy, and we were despairing, and we asked you to form interact teams within your facility. And I think most of you did, but we'd like to do a quick poll, if you can. Do you have a team at your facility currently working on interact implementation? I'd like to give you about 30 seconds to answer that question. And we're off.
Hey, Emily, it's Morgan. Can you hear me?
It's not working.
It's not working.
It's not working.
There we go.
There it goes. Okay, so if you can answer that question, do you have a team at your facility working on things?
Okay, now it's up. I have no idea what's coming down the road.
And you just fill that little radio button and hit submit.
There you go.
Okay, so quite a few people do. Thank you for answering that question. So, if you have a team at your facility or are using an existing team to work on interact implementation, can you share with us a little bit about how that went for the benefit of all participants? If you formed a new team, how did you go about convincing people that a new team was needed, that they had the time and the resources to do this? If you used an existing team and you want to share a little bit about how you got this on the agenda and have been able to use an existing team to do this work, if your experience after having a few meetings is that there are people who need to be at the table who are not at the table, so we need to share your thoughts about that. Are there people at the table who you wish were not at the table? You can anonymously share your thoughts about that. And how you've discussed the initiative with the staff and whether or not line staff are participating in the team. So now I'm going to ask you to unmute your phones, and if you have a story to share, please do. You might have to press star 6 to unmute your phone.
No. You cannot change that form, but
Anyone want to talk about how they formed their team and got support from executive staff and medical directors to do so?
and they're only asking as it's not showing up correctly. I don't put that. Getting that, it's not pulling out the right information. Correct. Well, what does that mean? So that I can add in like the whole cool.
Okay, we have a little background noise. I want you to unmute your phone if you're going to talk to all of us, but if you're talking to the people in the room, it's better off staying muted, or else we'll participate in that discussion passively. Anyone want to share about their team?
Is Bonnie Ganem on the call. Can you unmute your phone and share with us how your team is going? Bonnie, can you press *6, please? If we don't have volunteers, we're just going to go up and down the attendance list to have you share with us.
Fine.
See the chat.
I have to remain on mute. It's going to get very loud here in just a few moments.
Okay. Well, Laura has shared in the chat box with us that they started at the Director of Nursing and the nursing home administrator level, training the Interact program, and then introduced it to individual facilities. That's great. Anyone else have something they would like to share?
I don't know that.
All right.
Here, we'll give it to you.
Thank you, guys.
All right, we'll move along. Florence is going to talk a little bit about the readmission tracking tool and ask how that's going. We might get a little bit more feedback on that because that's a hot button issue.
All right, everyone. So the first tool that we talked about during this series is the readmission tracking tool. And this tool helps you to keep track of who's coming into your facilities and who's going out, who's actually starting the process, or who's making the transfers occur as far as staff, whether it's your medical staff or your facility staff. Now, if you remember, I asked you if you had not started using the Interact tool itself, that you should download the Advance in Excellence tool, and we went through how to enter the data. And I promised you that inputting your baseline data was going to be the most difficult part of using this tool, and I've gotten that feedback from a lot of people. Two things that I want to make sure that you remember about this is that when you get someone into your facility, their name is highlighted. They're transferred in from an acute care facility. It's highlighted in yellow, which starts their 30-day clock. So anyone that's highlighted in yellow, your staff should be acutely aware of any changes. They should be monitored more so than someone who's not highlighted in yellow. As you're making rounds, these people should be discussed. If you're doing any huddles, they should be brought up. They should be talked about at morning meetings. Everyone in the facility should know that this person is at risk for a 30-day readmission. Once they turn red, that means they actually did experience a 30-day readmission. So what we want to do is to keep them from ever leaving the facility and putting them at risk to be readmitted. So we want to just prevent any transfers at all. And using this system helps you keep track of that. There's some facilities who have point-click care as their electronic documentation system, and these Interact tools are embedded in that system. Don't forget that when we started this, I asked you to start with the required fields. Those are the fields that are starred in red. And then as you move along every month, try to fill in another section so that when you're starting out, it's not so overwhelming. So we should have had our first data available June 1st. And please do not send your entire document when you're submitting your data. You just need to take the numbers that are available on the graph section. Those are the numbers that you need to enter into the Advance in Excellence portal. And I am still available to help people to walk you through this process. And if you're not from Connecticut, you can reach out to your contact in your state. All right, so I have a polling question for you.
And the polling question is asking if you have started to input your data into
It's like this is
Advance and Excellence.
and the hospital transfers.
Are you using a computer? Are you using paper? And are you tracking? And give you a few seconds for that. Please don't forget to hit submit so we can get your results.
The clinical, so if you have the clinical tab, then you can see all this stuff.
Somebody should be doing it last in. Wouldn't be very good. All right, we should have results up in a few seconds. Again, don't forget when you submit your data, we only need just the numbers. If you send your entire document, it has patient protected information on it that we don't need being sent live.
18 computers. 8 out of 88 to paper. Other forms, 14.
All right. This is a bit concerning to me because we really need people to submit data electronically so that it's easier to receive the data from you. Also, when you submit to Advance and Excellence, you get that ability to benchmark yourself. Advance and Excellence will send you monthly data, and they will benchmark you against yourself, against people in your state, and against the nation. So the more people that submit data, the better the benchmarking is.
I did already. None of them look like that list that shows the yellow people.
There are 36 people who did not respond. Those that did not respond, would you be able to chime in?
Oh, no. Chime in. Do we
have
it?
Chime in.
To unmute your phone, so just to let us know why you didn't answer the polling question.
I tried to answer it and I clicked the wrong one, so then I...
Oh, no.
So we are using it here at the Vermont Veterans Home, and so I'm sorry I wasn't in that pool. I clicked the wrong one and I tried to correct it, and I guess I undid everything, so we are using it.
Are you using it electronically?
Yes. Yes.
Okay. Did you try to submit data this month?
No, I haven't submitted data. And Gail's coming to see me on Monday, so we'll get that done.
All righty. And if you're struggling, even when Gail is there, Gail has my number.
Okay.
You guys can call me and I can walk you through it.
Great. Thank you.
All right. Awesome. Thank you for the feedback. Anybody else?
This is Brandy Walton from Marshfield in Maine, and we are utilizing the Advancing Excellence tool for input. We have not submitted the data, but we are using the electronic tracking tool.
New finishes and furniture, as well as new large external patios for our
Someone has
residents.
put us on hold, but we'll try to struggle through.
All guests have been muted. You can unmute your lines by pressing *6.
We are available for you anytime.
All right, we will try to struggle through over the
Or after
the whole
our
button.
referral line is answered 24 hours a day, 7 days a week.
So this is a note to all of us. Please do not put us on hold because then we'll hear your messaging and your outgoing music. Thank you. All right, we will move on. So the next tool that we talked about was the medication reconciliation worksheet. And this is just a form to help you look at reconciling your medications either on admission, initial admission, whether it's from home or the hospital, and then using it with any readmissions also. And when you're getting someone in from home, it's important to have them actually carry their medications in and not necessarily bring a list that they're working off of. because we know that most of the time a list is not as accurate as actually seeing the pill bottles. Sometimes they have a list that's about 2 years old, and we know that things change often. So this document should be used by those who actually receive the medication. So it could be a supervisor that's helping on the unit. I actually had one of the facilities here in Connecticut give me a call to give testimonial as to how they're using this worksheet. And she said that usually the supervisor would start it, documenting all the medications that have been received. And if that person is unable to complete it because they've run out of time or their shift is over or they have to be called off to someplace else, it's passed on to the next supervisor or the charge nurse. So it's a system that is started and is completed. She finds that it's actually helping them reduce the amount of med errors on their units. Having said that, we will move to the next polling question. Have you used this medication reconciliation tool in your facility? Again, please do not forget to hit the submit button.
See the point there, not using the user defined assessment. That's what I said.
Is she using now?
That might be credit.
All right, we will give you a few more seconds to finish answering, and then we will have some discussion, and hopefully someone will speak up so I don't have to pick on you. All right. 46 answered no. Of the people who answered no, would someone like to speak up and just tell me why? We need the feedback so that we can figure out, what we can do to change the system and make it work better for people.
Hi, this is Vermont Veterans Home again. And we don't use it. I just find we have a procedure that works faster and better for us than that tool.
Okay. Do you actually have a tool or you just have a process?
We have a process.
Okay.
This is Robin calling from Coventry in Rhode Island.
Okay.
We're not using it. I didn't even approach implementing it because in Rhode Island we have a very detailed interagency transfer medication verification thing form that comes from the hospital with the resident or from another facility if they transfer over. So it seemed very redundant to what we are doing.
Okay. Thank you for sharing that. Would you mind emailing me a copy of that? Just kind of take out your patient information. I'd just like to see what it looks like.
I can. It's a computerized form that the hospitals print off.
Okay.
And it's verified on their end, and then our doctors review it, and then verify they want to renew everything, or they strike something out and make the change they want to make. So we have that documentation of what they had in the hospital, what was keeping, not keeping, changing.
We use the same process ourselves.
Yeah. In Vermont?
Yes.
Okay. All right. But I'd like to know, because if people are doing that system out there, I'd like to see what it looks like. Maybe Connecticut can jump on that bandwagon.
Absolutely.
Thank you for sharing. Anyone else?
Actually, coming from Rhode Island too, we use the Interact tool in addition to what Coventry has to say about the hospital process.
Okay.
We found inconsistencies with the hospital process and reconciliation of home medication use with hospital medication use and what they're coming in with. So we found on our end that the tool with Interact was actually more accurate than what we were being provided by the hospitals. And now being based in California, I'm implementing that same tool in my facilities here.
Awesome. That is great to hear.
Excellent feedback.
Anyone else? Okay. All right. And then the next tool that we talked about was the quality improvement tool. And I shared with you guys that this was a tool that a lot of the care transitions communities here in Connecticut are using to do their case reviews. So this tool you would use after a transfer, whether the transfer ends with a readmission or it's just a transfer that ends up being an observation or comes back the same day. What you want to do is review every single transfer that occurs in your facility to ensure that everything was done properly. And at the end of it, I always say to people, at the end of the review, you may say this transfer was absolutely necessary. Every step was taken to ensure that this was needed. And then you give yourselves a pat on the back and you celebrate it. But if you use a tool and you find some areas and opportunity for education or for improvement, then kudos to that too. But the biggest thing that I want to point out is that everyone that's involved with that transfer should be at the table completing this tool. Because everyone sees something differently and all input is important. And it's also important to let everyone know that this is not a punitive exercise. It's an exercise to improve your process and your system. So the aide, if the aide was involved, should be invited because they see something totally different than nursing does after they come onto the scene. It's housekeeping, so any ancillary staff, if it's a family member, you need to get their input and make sure that your review is as complete as can be. Okay, so polling question, surprise! Has your team used the quality improvement tool to review a resident transfer? Yes or no? Don't forget to hit the submit button.
No.
Fine, I don't know the other.
When was our QAPI meeting? Okay.
No, it does.
All right, few more seconds, and then we'll hopefully there's some people waiting at that to speak up and share with us. Otherwise, I'm going to pick names.
No, they're like each other.
Yes, this is awesome. Almost 50% of you using it. All right. Okay, of the people who said no, could you please share with me why you're not using it or like feedback?
There's another reconciliation tool.
Actually, Hi, it's Vermont again. We haven't started using it, but we certainly want to start using it soon. It's a great tool.
Do you know what's preventing you from using it right now?
Well, we're in the midst of starting point-click care.
Okay.
So we have a lot going on.
Okay.
And
all right.
It's just timing right now, but yes, we are going to start using it.
Okay. Yes.
Hi, this is Christine Moore from Somers Manor in Somers, New York.
Okay.
Can you hear me?
Yes. Yes.
Yeah. We actually do review the transfers, but we don't use the tool. Our medical director usually reviews all transfers out. And I'm sure that much of what's on the tool she addresses, but I think for us, I think we're going to start using the tool because I think it's a good way to track it.
Yes, and not only that, it becomes part of your QAPI process as you're involving all team members. So, yeah,
We do review it at our quality, our QAPI forum, and we meet with a fair degree of regularity, but I think to make it part of a document review and make it part of whatever interventions we put in as a result of, monitoring, I think it'll be very helpful to us.
Okay,
We're going to do it.
All righty. How about, is there anyone in Connecticut that's using this tool and would like to testify? I see your name's on the list.
This is Robin Legati from McLean.
Hi, Robin.
Hello. We are using the tool, and we find that it's definitely helped us look at our processes, and a couple times, not that we could have prevented the hospitalization, the readmission, but it's shown us a couple things that we've done that our director of nursing has decided to change our processes just to keep a closer eye on folks when they first come to us from the hospital to begin with. And I think by going through that whole form and really looking at things, it's kind of brought to light, oh, well, gee, maybe we need to keep them on I&O a little longer, and maybe we need to, just some process tightening or enhancing maybe is the right word that's come out of this.
That's great. Thank you so much for sharing that.
Hi, Florence, can you hear us?
Yes.
Hi, this is Lori from Vernon Manor.
Hey, Lori.
Hi. We use that tool on all of our transfers for the ER and for readmission. But we also take that information and use it to fill out our Advance in Excellence sheet to fill out the same information that they ask on Advance in Excellence.
That's very good. All right, awesome. Thank you. Thank you all for sharing. Back to Sheila.
Hi, Sheila back again. But don't think you're off the hook with Florence because she's got all your names on a list here, apparently. She knows who's been naughty and nice in the world of Interact. Our last session we talked about the communication tools. We talked about the stop and watch tool. Okay, which is a tool that's used by CNAs, rec therapists, housekeepers, all line staff to report subtle and new changes in resident conditions. It's an early warning tool. It allows line staff to report changes, almost intuitive differences in resident conditions without feeling awkward. It also provides a loop where the CNA can report back up to the nurse and the nursing supervisor some observations, have the patient assessed, and then hopefully that information will go back to the CNA, housekeeper, or rec therapist as to what was determined about those subtle changes. So I hear that CNAs will report things like the resident seems more tired, less interested in activities, eating poorly, things like that. So this is a pretty powerful tool, and it usually generates some interesting stories. So I'm hoping that someone would like to share that, the implementation of the Stop and Watch tool, if you want to share a little bit about how that was received by your CNAs, and maybe a story of how it was used and how it helped identify a change in resident condition early enough for attention to be performed before the resident's condition deteriorated. So anybody want to tell us about a Stop and Watch?
I have a story for you, Sheila. This is Florence. I had a facility from Connecticut give me a call and told me about an incident where an aide actually reported to the nurse using the Stop and Watch tool that one of her residents had a swollen leg. And in doing the testing, they found that she had phlebitis, and they were able to treat her in the facility without having to transfer her out. And this is exactly, how we want the tool to be used. She reported it, the nurse acknowledged it, and did the evaluation, and treatment was started right in the facility.
Thank you, Florence. I'd like to remind you as well, if you're not sharing a story, that you put your phone on mute because there's quite a bit of background noise. But I hope you'll unmute your phone and tell me something about Stop and Watch.
Tina from Avon, you're on the call. Would you like to share a story of Stop and Watch with us?
We did use the Stop and Watch our staff. We inserted studying all the students. Right now we're in a circling back round. It's only been used a few times.
Who is speaking, please?
Avon Health Center?
Okay. So, can you repeat what you said because you were breaking up a little bit?
Can you hear me now?
Yes.
Start the Stop and Watch program at Avon, and we introduced all the staff and all of the departments, and during the in-servicing it was very well received. However, right now we're in the process of conducting a root cause analysis because we've only had staff members actually use the Stop and Watch pad. So we're in the process of trying to figure out how we can get more use out of Stop and Watch and figure out
All right. Well,
that's a great approach to take. You try to implement it, and you go back. I'll talk a little bit about the PDSA cycle as such a powerful way to implement new processes. You tried something, you had a hypothesis, you tried it, it failed, and you're going back to try something else.
Not a story, but we're hoping to get there.
You will get there. You will. I'm absolutely confident. Okay, and then the SBAR tool we also spoke about. Again, if you could mute your phone if you're not speaking, that'd be great. The SBAR tool, the structured communication tool, situation, background, assessment, and recommendation as a way for nursing to communicate with other nurses as well as other professionals. This has become an industry standard. It's taught in medical schools and in nursing schools. It's definitely a standard in all the acute care hospitals in Connecticut. So, hopefully, you've been able to get that process up and going among your nursing staff. And can you tell us whether or not you have you implemented the SBAR tool in your facility? Here's a poll and test. We'll give you a few seconds.
Some kind of diagnosis. I already have Dr. paperwork of, kind of protocol that you don't have. Keep calling the doctor, you just say, this one is this, how is it? So I'm working on it.
Take a few minutes to fill out that polling question. Again, there's a group of people speaking, and we can hear everything you say. So if you mute your phone, it will protect your privacy. Could everybody just check that their phone is on mute? If you press star 6, it will make the phone. Okay, here we go. All right, here we go. That's great. That's terrific. It looks like a lot of people have implemented this. And as I said, this is going to be an industry standard going forward. Okay, I'm going to ask one more time somebody with a lovely lilting French accent to be heard throughout this conference. So if you're in a room and speaking, if you could mute your phone, that would be wonderful.
doing extraordinary thing. I'm telling you that because I'm so excited about.
Okay, moving along. If anyone has a loud and booming voice like myself and wants to share something about how you've implemented these tools, because it is a challenge, as the participant earlier was saying, you might send it out there once and people are enthusiastic and they say this is a great idea, and then 2 weeks later you realize no one's done it. So if anyone has anything to offer in terms of a suggestion as to how to move these implementations forward, something that worked, something that didn't work, let us know. Jackie?
This is Lori from California.
Hi, Lori.
It's very hot out here. What we did, because we are all electronic, and we were all electronic when I was in Rhode Island too, is actually implement that SMART tool into all of our change of condition events. So when the nurse is treating a change of condition event, starting whatever clinical area may be affected, respiratory distress, COPD, a fall, whatever.
And of course, that's the best solution, Lori, is when things can be implemented into electronic health records.
So we're signing off because we can't hear anyone or anything, and
I'm so very sorry.
we're just Branford Hills. We're signing off.
Okay, thank you, Brentford Hills, for your patience. Okay. I guess we'll wind down again. We've got some bad background noise, and it's due to someone's unmuted phone. But I would suggest again that if you try to implement these programs and your implementation plans fail, go back to your PDSA cycle. Go back to a hypothesis as to what would work. Do it, study it, did it work or not, and then act, change and tweak whatever program for implementation that you had. So, if you sent out those stop and watch forms and no one's using it, go back and do a root cause analysis. Brilliant way to go about it, and then try something else. And I think we've got some silence on the line. Oh, Carol.
Okay, last but not least, it's Carol back to finish up our webinar for the month of June. Just to let everyone know, if you have missed a webinar since February, they are all posted on the New England QIN-QIO website. What you would do, here's the link to the New England QIN-QIO website. It's www.healthcarefornewengland.org. Once you get to that landing page, right in the center of the page, you will see the Events tab. You're going to click on the Events tab, scroll down all the way down the page to the previous events. You're going to click on that link, and then you're going to scroll down to the webinar you wish to review, whether it's on Stop and Watch or the Med Reconciliation or the most important one, and we can't stress it enough, is about the readmission tracking tool, that everyone should be tracking your readmissions. The hospitals are very interested in their readmissions. You should be interested in your readmission. And then you can click on the recording link so you can get the audio recording, and then you can also click on the presentation link, and the slides are right there. So again, it's www.healthcarefornewengland.org. So before we leave for the day, does anyone have any questions for Sheila, myself, or Florence? And we, again, are so sorry for that background noise. We have no control over it on this end.
Hi, it's Sue from home. I have a question.
Sure, Sue.
Hi there. We purchased the Stop and Watch duplicate pad, and we're getting ready to roll it out. I was just wondering if anybody could give us any feedback on what the process was. I mean, we were thinking that, a CNA or any other ancillary staff member could complete the form and give it to the nurse, and then kind of like, what do you do from there? The nurse does an assessment, and then how do you track it, and how do you be sure that
the nurse follows through on the process. Just curious on if anybody actually put together a process for that.
Hi, Sue. It's Florence. I'll start by saying that, once you start the process, of course you're going to start with educating all your ancillary staff as well as your nursing staff so that they know that this is coming and that they're receiving the information and doing something with it. So once the duplicate is filled out, the white copy goes to the nurse and the aide or the person reporting it keeps the carbon copy. The nurse does the assessment, and then the white copy now gets clipped to your 24-hour report. It's discussed at morning meeting. Whatever the outcome of the assessment or the evaluation is, someone has to get back to the aide or the person reporting it to say, yesterday you reported on Mrs. Jones, this is what happened, this was the outcome. And then, if you need to continue to monitor based on whatever the assessment is, you need to keep reporting on that, however you do your 24-hour report until that issue is resolved.
Okay, that's helpful. Thank you.
And also that person, again, is discussed when you have your huddles or during rounding. So, once it's picked up, it needs to be looked at until the issue is resolved.
Okay, like any other change in condition.
Correct.
Yeah.
So I don't know if anyone else is on the phone that has used a different process, has learned anything differently than I have, and would want to share that with Sue.
Hey, Sue, this is Lori. We did the same exact process that Florence just explained, so we just expanded on it one step further and took it to our weekly at-risk meeting and discussed all those residents at risk with the IDP team. So we had all of the interdisciplinary teams there to expand upon that, ensure follow-through, and offer up any new suggestions as well.
Okay, that's interesting. Thank you. That's excellent. Thank you, Lori.
The other thing I would recommend, Sue, is that you maybe start on one unit and try it for a week or two, and review it and see if it's rolling out the way you want it. So don't go a long period. Don't go a month or two before looking at the process to see if it's working. Start with one unit and then do it for a week or so, a week no longer than two. Review it. Go back to if you notice that they're not using it, go back to the aides and say, what's going on, and feel the temperature. See if you need to change anything before moving on.
Okay, great. Thank you.
Welcome.
And the other recommendation is you always have these tools in a very local place where everybody can reach it. So it's visible. You talk about it maybe every morning at staff report, just to make sure everybody's aware that this is a new tool and what's it for, and it's all about the residents. So that's another recommendation that has come up through our discussion.
Any other questions?
I have a question.
Sure.
Yes. Ellie Mercer from the Mary Wade Home. You mentioned that, Florence, I believe you're available if we need help with advancing excellence and entering our data. What would be your contact information?
My number here, and it's going to show up on the screen, is 860-613-4187.
Thank you.
You're welcome.
Any other questions for us? Or for each other, for another nursing home to another nursing home. And that's really the all teach, all learn environment that we're really trying to get across. We have Florence here as the certified trainer, but it's the nursing homes that are using the tools, that are seeing the challenges and overcoming these challenges and to share that information so your colleagues can also overcome those barriers and not get stuck.
I have, not a question, but I guess it is a question.
Okay.
You hear me?
Yes, we can. Please go ahead.
Is Andy through this in Mary Wade Home also? I just wonder, this is a great forum for teachers to also share best practices, you know, speaking of their protocol. We heard somebody say they teach some protocol. You know, is this a good chance for everyone to share best practices that have helped them with regard to these goals?
Absolutely, absolutely. And after every webinar that we have, we do spend some time talking about best practices and talking about the challenges. So absolutely. And that's why we decided to have this call today. As Sheila said, we're 6 months into it. We wanted to see how things are going and also to share what's working and what's not working. We really need to have those. Everybody put on mute, please. Any other questions or ideas you want to share with us or each other? Okay, with that being said, we'd like the Connecticut nursing homes to stay on the line, and all the other nursing homes, thank you so much for your time and your patience today. We will be working with CMS to figure out why all this background noise was present today. We are truly sorry. Thank you for persevering, and we'll see you next month, July 29th. We are going to be talking about part 2 of the communication tools, the transfer form, the envelope, the interactive envelope with all the documents that need to go with the resident if there is an acute care transfer. It's going to be a really important webinar, and Morgan has a few last-minute details to share.
All right, as you guys close out of the webinar, it will direct you automatically to the evaluation for today's session. We know that the noise was a problem, but let's focus on the content. So if you don't have a chance to fill that out right now, you will get an email tomorrow with the link to fill it out. So if you're sharing the computer with somebody else, you guys will both have the opportunity. The presentation is posted on the website already. In the next few days, we'll have the recording and the transcripts up there as well. And as Carol mentioned, Connecticut folks, stay on the line, and we look forward to seeing you guys next month.
Bye, everyone, except for the Connecticut homes. Okay, this is Carol back talking to the Connecticut homes. Just want to let you know, good news, guys, no homework this month. We thought we want to celebrate all the work that you've been doing, and also with the good discussions that we had today over the noise. We would like you to go back to your teams to talk about each of these tools. How are you doing? If you're not using the tools, why are you not? And so that's really the homework, just to go back and look to see where the gaps are. All these tools are so important for your residents. So we wanted to celebrate, give you a month off, and we'll see you back on July 29th at 1 o'clock, and we will be presenting the communication tools as I mentioned. Now with everyone else jumping off, are there any questions from the Connecticut homes? I hear smiles right now. That's what I hear. Just nice, quiet smile saying, thank you. Okay. Thank you very much. Okay, guys, so we'll see you next month. And have a great month. And don't forget to reach out if you need support. Don't struggle out there by yourself when you have us here to help you. Thanks, Florence. All right, see you guys next month. Bye-bye. Bye.